All right, guys, so welcome to week 10. So we got a bunch of stuff, pharmacokinetics, which is a part of pharmacology, tissue repair and healing. So that's stuff about just general cell stuff. And then medicine of the mind and some HKS. So let's get into it. So pharmacokinetics. So pharmacokinetics is essentially the study of what the body does to the drug, right? So there are a couple of different steps before we think about what the drug does to the body, because we still got to do things like absorb it, metabolize it, and then excrete it as well. So as you can see on the slide, so absorption and distribution is what we're going to focus on first, and then we're going to move on to metabolism and excretion after. The contrary is pharmacodynamics, which is a study of what the drug does to the body. So that's essentially the stuff about drugs binding to receptors and them having an action on the body. So pharmacokinetics is pretty important because we want to get our drug doses, the timing correct. We want to think about routes of administration. So how we're going to do it, the starting dose, and we want to sometimes get the drug concentration to a certain concentration so that it's not toxic and it's not ineffective. And also a bunch of other stuff like avoiding drug interactions, preventing adverse effects, managing overdose. And yeah, like I said, attaining a plasma concentration that's in that therapeutic range. So routes of administration, there are a lot of different routes. I think understanding the routes and how it works is the most important thing. But it's also good to know some examples. So for example, injections, I think we all know what an injection probably is. But obviously there are different types of injections. You can inject into the muscle, inject into, in this case, intravenously, which would give you rapid onset of action. There's oral, which is abbreviated as PO usually. We have sublingual, so that is directly into the vena cava. And that is, if I'm not wrong, done sometimes underneath the tongue. It avoids stomach acids and gut enzymes. So an example is nitroglycerin. Rectal, diazepam for epilepsy. Intravaginal, so makes sense, inside the vagina. We have antifungals for thrush. Intraurethral, inside the urethra. And that's prostaglandin. Transdermal, so that's on top of the skin. So we have like nicotine patches, I believe. Inhalation, so that is drugs that are inhaled, for example, for treatment of asthma. Intranasal, that is drugs into the nose, and that's like corticosteroids. There's topical stuff as well, so on the skin, on the eye, on the ear, etc. And we have a lot of different types of routes, but how do we actually pick the route, right? Typically, we want to do oral for compliance because it's just easier to do and track, especially for patients. But there are a lot of other reasons why we would do other routes. So for example, we wouldn't do PO if the drug is rapidly inactive in the GIT system, if the patient's vomiting, and because of whatever disease state they're in, absorption is limited, we can't do that. If the patient's unconscious, they can't swallow. And also, when we do oral stuff or intravenous, the drug does lap around the body in the bloodstream, and that can result in systemic adverse effects. And if we don't want that, then we should, not give it orally. So there are multiple factors affecting absorption and distribution. So here's 4 of them. So when we have pharmaceutical form, and then the reason why that is relevant is because the dispersion or dissolution of the actual active ingredient in the pharmaceutical form would change depending on what way we're administrating it. Tablet dissolving is relevant for absorption because we need like the proper conditions necessary for it to dissolve and to actually release the active ingredient. And once the active ingredient is released, things like lipid solubility, ionization, and molecular shape and size become more relevant because we want the active ingredient to get into the body and be distributed throughout the body. So we're going to talk about lipid solubility and ionization in the next slide, but for molecular shape and size, for example, large bulky molecules diffuse lower and are less likely to cross membranes. That's just an example of how this factor can affect absorption and distribution. Diffusion across membranes. So there are a lot of different ways that drugs can diffuse across membranes. And this is obviously relevant to the solubility stuff. But for now, we're going to talk about 3 different types. So that's passive diffusion across lipids. So again, it needs to be lipid soluble for this to happen. There's passive diffusion across aqueous channels, and there's carrier-mediated transport. So we see carrier-mediated transport, especially if they're endogenous substances, meaning they're substances that are created by the body. Because if they're already created by the body, then it makes sense that the body would already have endogenous carrier proteins, meaning the body already has proteins to carry it across, since it's not some random thing externally that the body doesn't know what it is. There's also the idea of bioavailability. So that is the proportion of the drug that reaches the systemic circulation as an intact drug. So this is affected by pharmaceutical formulation and release of the drug, because if we have a drug that is not well released, then the proportion that reaches systemic is going to be decreased. And first pass metabolism in the liver. So you guys are probably going to talk about the portal system later on in med, probably like year 2, but understand that stuff has it can be metabolized in the liver before it reaches the bloodstream and enters the systemic circulation. So that is obviously relevant, because if it does not reach the systemic circulation and is broken down before that, then bioavailability is going to be decreased. All right, so going back to lipid solubility. So we talked about how it can diffuse across the cell membrane, and this is dependent on if it is soluble in the lipids. A lot of drugs are weak acids or bases. So there are 2 states that they can be in. They can either be ionized, and when they're ionized, they have low lipid solubility, or they can be unionized and such have high lipid solubility. So you guys might recognize these sorts of equations from equilibrium in chemistry, if you come across that idea. But it essentially, these weak acids and bases are understood as existing in an equilibrium. What that means is we have some of the left-hand side of this equation. So some of this weak base exists as BH plus, and some of it exists as just B. And depending on the acidity of the environment, we see that it either exists on the left, like a lot more exists as BH plus, or a lot more exists as B. So it's a balance between those 2 types. So for example, in a basic environment, we can reason out that, so the base doesn't really want to take up more H plus since the environment's already basic. So it just remains as B. However, in a basic environment, the acid wants to release H plus to make it more acidic. So the AH is going to form A minus. So this would be an ionized form. So in a basic environment, the acid is going to be ionized, and so we'll have low lipid solubility. Equally, the same story applies. So in an acidic environment, base wants to take up H plus, so it forms BH plus. In an acidic environment, the acid does not want to release H plus, so it remains as AH. So ultimately, what we understand from all this is that dissociation and which form it exists in is dependent on the pH. And we have this idea called a pKa. And what a pKa is is just the pH of a substance when 50% of it is ionized and 50% of it is unionized. And we use this value to understand what sort of effects the drug is going to have in terms of moving across membranes in different parts of the body. But yeah, that's pKa. Now, ion trapping is going to be a problem, right? Since we said that in some compartments of the body, if it's more acidic, then the basis wants to grab more H plus, and it becomes BH plus, and then it's going to be ionized. And if it's ionized, it has low lipid solubility, and that means that it can't leave unless it has specific channel proteins or carrier proteins, since it can't move across the cell membrane easily. So there's a phenomenon called ion trapping, where essentially the drug is unable to leave since it's less able to cross the membranes when charged. All right, so in circulation, drugs, they don't just exist as the drug. They can bind to proteins in the blood. So for example, plasma albumin is a pretty prevalent one. And a lot of drugs can bind to plasma albumin. After it binds, it reduces the free drug in the circulation. So it turns it to become inactive. And since it's inactive, it's also no longer filtered by the kidneys. So excretion decreases and you just have an inactive amount of the drug in your bloodstream. When it gets a little bit interesting is when we have different drugs binding to the same site on plasma albumin, and they can displace each other. So for example, if you give anticoagulants to someone on steroids, the patient on steroids would have steroids already bound to plasma albumin. But if you give anticoagulants which compete for the same spot on the plasma albumin, some of the steroids is going to get kicked out of the albumin and get released into the bloodstream. So steroid activity is going to spike, even though we don't even know that they have steroids since it's all inactive and bound to plasma albumin. So that's something pretty important. So we just talked about absorption and distribution. So let's talk about metabolism or biotransformation. Drugs are eliminated through 3 different mechanisms. We have tissue redistribution, biotransformation. Okay, so tissue redistribution in circulation essentially means it is that once the drug acts in a certain place, it is just washed away back through the blood and it's just eliminated from the site of action. Biotransformation or metabolism refers to us breaking down the drug for excretion. So for example, we have lipid soluble, lipid soluble drugs become more water soluble, and that's a form of metabolism in the liver, and which primes it for excretion via the kidneys later on. So there's a lot of different sites. There's the liver, which is the main site, gut, plasma, and kidneys. Those are the sites for metabolism. And finally, we have excretion. So this is the way that it's removed from the body. So of course, it's via the urine, feces, bile, or lungs. So talking a little bit more about metabolism of drugs, most biotransformations are catalyzed by liver enzymes. So when drug concentrations increase, these liver enzymes can become saturated. And then something interesting happens. We have on the graph, if you can point your attention to the graph on the right. So we have plasma concentration on the y-axis and days on the x-axis. And every time the I guess the line spikes up, that is indicative of a new dosage given. So on the left graph, we can see how it slowly, after every spike, it eventually plateaus to a certain point. But on the right-hand side, every spike just keeps the graph going higher and higher. So the left-hand side is what we call first order kinetics or normal kinetics. So what it shows is that as the plasma concentration of the drug increases, more enzymes are recruited to break down the drug. So eventually it reaches a point where enough enzymes exist to catalyze it and keep the plasma concentration constant. On the right-hand side, however, we see zero order or saturating kinetics, because since the enzymes that break down the drug are saturated, the rate of breakdown is unable to increase or match the amount of drug into the body. So this means that whatever extra drug you put on is just going to keep increasing the concentration in the plasma, since more enzymes cannot be recruited. Typically, we see that at low doses of a drug, we see normal kinetics. That makes sense because at low doses, there are enough enzymes to have this sort of action, which to compensate the increase in plasma concentration. But at higher doses, we see saturating kinetics, which also, again, it kind of makes sense because the enzymes are saturated because that dosage is too high and it just keeps going up. And of course, it's all dependent on the number, like the amount of enzymes available. So saturation occurs or doesn't occur. So we have a bunch of different ones. We have alcohol, aspirin, and phenytoin, which are all understood as zero order or normal kinetics in general. Oh, sorry, zero order or saturating kinetics. And that is important to know when we're thinking about the drug and dosage schedule and amount and things like that. All right, so the final part about excretion. There are multiple different organs that excrete stuff from the body. So the kidneys, major site of excretion of water-soluble drugs. Previously, we talked about how the liver can turn drugs to become more water-soluble so it can be excreted. So yeah, we can have water-soluble versions of lipid-soluble drugs as well. Lungs can remove gases and volatile liquids. Gut, drug excretion through bile or feces. Sweat, saliva, mucus, tears, milk. So that's all of that can excrete small amounts of drugs, and this can still be dangerous though, because some drugs in the milk can be harmful for infants, for example. And that's the end of pharmacokinetics. If you guys have any questions, chuck it in chat and I'll keep an eye on it. If not, keep moving on. Yes, no, maybe. Any questions? How the difference between elimination and excretion? Okay, all right. So I think elimination is just breakdown and excretion. So it's kind of is like both things. So elimination, I think what they're referring is metabolism and excretion. And then, yeah, excretion is a part of elimination. If that makes sense. I believe that's the way they do it, yeah. Good question though, it's a bit confusing. But chuck any more questions in chat if you guys have. If not, okay, moving on to tissue healing and repair. All right, so you get injured, right? Tissue injury. How do we fix it? There's two different ways we can fix it. So if it's a reversible injury, we can regenerate the tissue. If it's a reversible injury, we can adapt the tissue as well. So regeneration involves rebuilding using the same material. Adaptation involves rebuilding using different material. So you can, in response to stress or injury, tissue adaptation involves replacement of different tissue. If it's irreversible, you get scarring. And on the slide, we can see the situations when either or happens. So we get regeneration or adaptation when the injury is mild and transient, but we get scarring when the injury is severe and substantial. The former when the tissue is labile or stable. So what this means is labile, I think it means that it can rapidly replicate, or it always goes through cycles of death and regeneration over and over again. And stable is that it's generally stable, but it can regenerate when needed. But scarring, obviously, when the tissue is permanent. In reversible injuries, it begins following acute inflammation. Scarring follows chronic inflammation. And yeah. So I want you guys to keep in mind that there are different pathways that the body can take in response to injury or stress, depending on the nature of the injury or stress. But now we're gonna go through typically what happens in wound healing. So there are 4 different steps, right? So hemostasis, hemo meaning blood, stasis meaning stopping of. So we have stopping of bleeding through a platelet plug, primary platelet plug, and a stable clot. That's, yeah. And then we have inflammation. So that's the stuff we already know: redness, heat, swelling, pain, loss of function, proliferation. Okay, so proliferation refers to, we're going to come to this. So it involves granulation tissue organization, rebuilding of collagen, and ECM and epithelialization. All of that we're going to explain in the next few slides. Maturation is when the collagen that is built or rebuilt in step 3 is remodeled to improve strength. All right. So now we're going to go through different types of wounds and the different ways in which we heal. But what we understand is that in general, it follows the same structure outlined right here. So that's something I want you guys to keep in mind. Even if the ways that healing occurs looks completely different, I want you guys to try and relate it to these 4 steps, and it will make a lot of sense. So healing by first intention. So this typically occurs in small cuts where the exposed edges remain in contact with each other, such as clean surgical incisions. As you can see on the bottom right, it's like just a clean slice. Heals to about 70 to 80% strength in 3 months. Not bad. So step 1, hemostasis, platelet plug, stable clot, inflammation, and then we have weak fibrin that joins the incision. Fibroblasts produce collagen for a strong joint. And epithelialization refers to the formation of more epithelial cells on the surface, which close the wound over. So you can sort of relate steps 1 and 2 to hemostasis and inflammation. And basically all these ones are proliferation. And at the end also maturation happens. So the collagen laid down by the fibroblasts cross-link to improve strength. But yeah, these are steps 4, healing by first intention. Next, we have healing by second intention. So I'm just going to show you a picture. Okay, yeah. So on the top, we have primary intention or first intention. So the wound is much thinner. On the second one, we have healing by secondary intention, where the wound is much bigger and flatter and fatter. So in this case, the surfaces of the epithelium do not approximate or do not come into contact with each other. So it's a large wound. So it occurs in large wounds with extensive cell and tissue damage, such as burns, ulceration, necrosis. The wound ends don't come together. So typically it involves a combination of both regeneration and scarring. I just got a question asking, is healing by first or second intention considered scarring or irreversible? So first intention is typically pretty reversible, but it's a combination of both factors, because you can leave a scar in this case. As you can see in the bottom right, it's a hairline scar, but regeneration also happens. So yeah, if the injury is more severe, you're gonna see more scarring. But if the first intention healing it's like a paper cut, the first intention healing still applies, and you're not going to see scarring. So it's very situation dependent. But in the case of scarring occurring, there's typically also some regeneration, as we can see in the slide. So even when wound ends don't come together, it involves both regeneration and scarring. So the steps, right? Hemostasis, inflammation, and we have a new structure called granulation tissue. So what this is we have endothelial cells, so that's cells of the blood vessels, proliferate and growing into loops in the damaged area. So this is essentially exposed capillary cells or capillary beds on the surface of the damaged area. And these loops, they open into obviously the blood vessels and the vascular channels. And it kind of looks like this, like the surface. So in granulation tissue, we can see budding capillaries on the surface of the skin, on the surface of the body. This is obviously to supply and nourish the wound with blood for nutrients and things to, and like other cells and stuff to help heal. Next, we have proliferation and stimulation of fibroblasts to become myofibroblasts. And these myofibroblasts, first of all, they secrete collagen, and they also contract and pull the granulation tissue together to reduce the volume needed for repair. So it's kind of like in the second picture, where the ends of the wound actually pull together to reduce the amount that needs to be healed. The collagen that is secreted by the myofibroblasts then accumulates to form a tissue scar, a fibrous tissue scar. We get the same epithelialization, so that's epithelial regeneration. And we would have the same maturation process where the collagen cross-links and forms stronger bonds, essentially. So going back to this slide, so we saw granulation tissue in proliferation, rebuilding collagen. Extracellular matrix is also rebuilt because it's damaged, and then epithelialization, and then final step of maturation. So applying that same principle, so we just saw wound heals on the surface of the skin. Now we can look at GIT infections, for example, or in injuries. So there are two different types. We have mucosal erosion or mucosal ulceration. Erosion is loss of part of the thickness, but ulceration is loss of full thickness of the mucosa. And mucosal erosion will give you full regeneration with no scarring and rapid epithelialization. And this is obviously first intention. Ulceration, since you lose a lot of your mucosa and it can involve deeper layers like your muscularis propria, this needs to involve granulation tissue and second intention healing. And again, bone injuries, we can still draw parallels since the underlying process is the same. So hemostasis and inflammation occurs. The highly vascular bone forms cartilage callus. And the new thing here is the osteoblasts, which kind of make a cartilaginous structure, but we still have fibroblasts. And then instead of secretion of collagen to sort of recreate the tissue, we have the cartilage remodeled to form new bone. You guys might come across it when you think about, when you learn about how bones are formed through ossification. And it's a kind of a similar process where cartilage is remodeled into bone. All right, so factors influencing repair. So there's a lot of situational based factors that can influence how fast and how well the repair occurs. So for fractures in specifically, infection is always a concern. Movement of the bone when repair is occurring. So we want to keep it immobile. Misalignment. So if we do not keep it immobile, then it can grow back or heal back in a manner that we don't want it to. So that's in a misaligned manner. If there's soft tissue stuck in between the fracture, then that's going to be a problem. Bone disease is going to be a problem as well. But for general tissue healing, again, infection, nutrition is important. Glucocorticoids, that's a drug that can sort of inhibit tissue healing. Poor perfusion makes sense. We want blood to transport stuff. foreign bodies, location of the injury, aberrations of cell growth, and mechanical variables all are factors as well. Oh, I just got a question. In bone healing, what type of cell makes the cartilage in the middle of the bone? I believe those are going to be osteoblasts or osteoclasts. That's something that isn't super high yield or relevant, but I'll get back to you in a second while I hand over cell death and apoptosis to the next person.
Thank you, Duet. Just share my screen. Can you all see my screen?
Yep, looks good.
All right. So we kind of touched this topic in week 1. We talked about apoptosis and necrosis. We talked about apoptosis in detail. So if you feel you need to know more about apoptosis, you can go back to the slides from week 1, cell proliferation and cell death. Today we'll talk also in detail about necrosis. So cell death is a result for irreversible injury. So the cells will not be able to adapt to this injury or regenerate because the injury is severe, continue, and progressive. And we have 2 main pathways, apoptosis and necrosis. So we had also this comparison from week 1, the differences between apoptosis and necrosis. Apoptosis is kind of the regulated normal pathway. However, necrosis is a result for abnormal cell death or unexpected cell death. So apoptosis is highly regulated and cells shrink. However, in necrosis, cells are swelling and eventually they burst. Apoptosis can do not cause any damage to the surrounding cells and cause no inflammation at all. However, in necrosis, it does cause inflammation and cause some damage to the surrounding cells, and the membrane integrity will be lost. However, in apoptosis, the integrity of the cell membrane remains. And apoptosis produces apoptotic bodies. So these products will not cause any inflammation or any damage to the surrounding cells, and they will be phagocytosed or broken down. However, necrosis do produce dead tissue, which can cause the damage to the surrounding cells. So apoptosis as it's a regulated normal process. We have these causes for apoptosis, which can be considered as normal causes, where the cell lose its function or it's too old to carry its functions. So you have energy failure, like oxygen lack or glucose lack, blockage of metabolic pathways, where interruption of protein synthesis occur, or respiratory poisons, hormone or growth factor lack. We have some sort of mechanical disruption due to trauma or osmotic pressure, failure of membrane integrity, membrane damage, because of the free radicals, and final DNA damage or loss due to chemotherapy or ionizing radiation. Then we have the causes of necrosis. So we have the loss of ATP for energy, mitochondrial damage or dysfunction, loss of calcium homeostasis, accumulation of reactive oxygen species, increased permeability of cellular membrane, and finally accumulation of damaged DNA or misfolded protein. So we can talk about the necrosis tissues or necrosis patterns based on their gross or morphological features. So we can say that these are the types of necrosis of tissues produced by necrosis. So we have coagulative necrosis. So it's kind of coagulative and caused by ischemia. We have fibrinoid, where fibers replace the damaged tissue. We have gangrenous. It's a special type for blood components if the injury or replaced tissue is blood. Then we have liquefactive, where it produces liquid. We have gaseous, so it's like a creamy material. And finally, we have fat, where fat replaces the damaged tissue. And that's it for necrosis.
Yeah. Okay, so we're gonna keep moving on to the medicine of the mind stuff. So get my slides up again. Also, I'm still gonna get back to that question, by the way. So just give me a bit. I'll do that after I present this part. But so we have medicine of the mind. So that's stuff about, it's essentially like psychiatry. But we talk about different things which are easily applicable to how we live our life. So I recommend thinking about this stuff in relation to your own experiences of it as well. But first of all, stress. So stress can be understood in 3 different ways: as an external stimulus, as a transaction, or an internal physiological reaction. So an external stimulus, the way that works is we're thinking of it as something that has an effect, a physiological or a physical effect. And we're gonna describe these events based on the severity of these effects. So Holmes and Rahi, they made a scale which measures different events, but there are some flaws in that, such that it doesn't account for variation between individuals. It's also a non-exhaustive list, but that was a way that we can understand stress. As a transaction, so we can consider events as a comparison or a transaction between the event and the person's capability or the ability to cope with that event. So stress becomes undesirable or pathological when the demand created by the event exceeds resources available to deal with it, i.e. the person's capability. The third way is simply thinking about it physiologically. So that's the process of fight or flight involving the sympathetic nervous system, which is a part of the autonomic nervous system, and the neuroendocrine system. So that's things like raising cortisol levels, etc. Again, just a quick bit of detail on the sympathetic and parasympathetic systems. So they both comprise the autonomic nervous system, and the sympathetic division has all of these effects shown on this slide here. So dilation of pupils, saliva, inhibition, Delex bronchi. It's anything that you can just put into a scenario where you need to escape from a tiger, for example. What do you want your body to do? And you just reason through it as such. Types of stress. So we have two different types of stress, you could call it. So you have acute stress and chronic stress. Acute stress is the stress that we are typically more familiar with. So it's stuff that is specific, significant events. So it's once it starts, you get stress for it before it starts, and once it ends, it's no longer a factor that provides you that much stress. So it still can be repetitive and routine, such as exams, but can also be one-off things like personal tragedies. Chronic stress, on the other hand, is stress that exists as a continuum throughout time, regardless of if it's a stress, if it really is it's not really an event that starts and ends. So it's an ongoing stressor like work stress. And it's characterized by a bunch of stuff. So we have demand, so that a lot of excessive work to do. Controllability, so a lack of control over the task demanded. Predictability, so it's not predictable in the requirements that the work provides or needs. It's ambiguous as well, in terms of unclear requirements. Stress has a lot of different types of impacts as well. We have short-term and long-term. In the short term, we can categorize it as cognitive effects, so that's poor concentration, emotional effects of irritability, nervousness, physical effects, and behavioral effects. That still translates to long-term effects as well, where we still see the cognitive, emotional, and physical effects persist, but the behavioral effects become a little bit more different and relate to more of social withdrawal, substance abuse, and isolation. We also have organizational effects as well. So again, going back to the chronic stress example of work stress, job dissatisfaction, absenteeism, high turnover, and low morale. Not only that, we have a lot of health impacts as well. So heart disease, it can theoretically impact vessel damage, and we know that stressors are linked to heart disease. Bowel disease, so there's different types, and you should know the difference between these two. So it has a strong association of irritable bowel syndrome, but less with inflammatory bowel disease. So not ulcerative colitis and not Crohn's disease, but irritable bowel syndrome. I don't think you should really be fussed about the details of it and exactly how it works, but just know that it's associated with IBS, but not IBD. Multiple sclerosis, yep, so acute stress has an impact on that. And going to alleviating and aggravating factors of stress. Social support is very important. So we know that it can help stress in two main ways. One's the direct effect theory and one's the buffering theory. So direct effect is it literally it creates a healthier lifestyle because of the people around you, and it improves your immunity physiologically. Buffering theory talks about indirect changes to coping mechanisms and indirect changes to your own appraisal of the stress. So your own understanding of the stress, which helps it. Personality. So there's 3 different types of personalities that we talk about, and they interact with stress in different ways. So neuroticism, so that's an anxious prone personality. There's an increased self-reporting rate, but actually no objective increase in illness. So that's good. Hardiness, so we define that as dispositional resilience, so just resilience in general, leads to actual physiological better immune functioning and less illness. Hostility, so if it's an angry personality, negative worldview, that leads to unhealthy behavior, worse physiological responses, more like worse chronic heart disease. So that's bad. Locus of control, so that's our perception of what is within or without our control. So this is good sometimes, but can be maladaptive. It's good such that we can control our exercise and what we can do to help the condition that we might have, but can be maladaptive if it's something that you have no way of controlling, but you still feel like it is on you to control it. All right, so so there are a couple of different like models and theories too. So one is the Yerkes Dodson curve. You guys might have come across this before, but it's essentially the bell curve on the right. So it shows that at low levels of stress or arousal, your performance would be low as well. But as stress or arousal increases, your performance slowly increases. But with too much stress and arousal, because of strong anxiety, you impair performance. Again, this curve looks different for complex tasks and simple tasks. So complex tasks require lesser arousal for peak performance. So it's going to shift to the left. So the curve would look a little bit more to the left. But for simpler tasks, we require more arousal for better performance. So we're not as bored when we're doing it. But yeah. Finally, we talked about how we can understand stress as a transaction, and we have the Lazarus's transactional model of stress. I don't think it's Michelle Lazarus, but another Lazarus. Anyway, it has a bunch of different steps for how we understand how stress works in relation to the person and the stressor. So first of all, the person has primary appraisal. So they appraise, by appraise, I mean, they sort of assign how bad the stressor is. So they appraise it to think about how bad it is. If it's really bad, then you would appraise it as a significant stressor, but it changes depending on the different characteristics. So for example, if you expected this event and it's a predictable event to happen at that time, then it's not going to be as significant of a stressor. If the stressor does not require a lot of life change, and it's just a small, minute thing, then it's not going to be a significant stressor. But yep, that's primary appraisal. Secondary appraisal is the appraisal of the personal ability to cope. So that is the person's appraisal of themselves. And third is we analyze if the primary appraisal is worse than the secondary appraisal. So same story if the demand of the stressor is greater than the amount that you're capable of, then we experience stress if there's insufficient resources. And coping is essentially overcoming the stress, and it can be done in a bunch of different ways. So it can be adaptive or maladaptive. So it can be adaptive. I mean, it can be maladaptive if it involves things like substance abuse, denial of the stress. So that's avoided coping strategies. But it can be adaptive if it's problem focused or emotional focused. So those are the two different types of essentially beneficial coping strategies. Problem focused is to deal with the problem head on. So for example, if you're stressed about a test, problem focused would be to study for the test. Emotion focused would be to is for things that you cannot do practical things for, and it's more to seek emotional understanding or closure. So yeah. All right, so more stuff of medicine of the mind. So we're going to talk about illness, becoming ill, and being ill, and how that makes sense to the body. All right, so becoming ill. There are different, when a person feels like there's something wrong with their body, they understand it in a certain way and they come to the GP with a presenting complaint about it. So there's a difference between signs and symptoms, which is important in this context, especially because symptoms is what the patient is going to come with or report, because that's an interpretation of a change in the body that they understand as a marker of disease. So a sign is what the clinician really needs for raw data. So that's an objective change in the body measured through clinical exams. But symptoms is what the patient comes in with a complaint of, since they understand it as something that's not good. So there's a big model. There's a bunch of, this is a model for symptom perception. So we have normal physiological things providing somatic information. We have disease processes providing somatic information, both of which are detected as signs, but some of which is understood and interpreted as symptoms. And then once the symptoms is understood, that becomes a health complaint. So there are a lot of different things that can impact this flow chain. One of them being negative affect. So negative affect essentially means negative emotion. So if the patient is in a frame of mind where their attention is focused towards threats, you're more likely to notice more things you're more likely to notice more things to be signs of stuff. And the selective attention as well. So that is some specific somatic information being overemphasized as a disease or a threat, but it's essentially still awareness of bodily processes. So both negative affect and selective attention would enhance somatic information being detected as signs. And there's also external things that detract away from detection of signs, and that is distractions. So that's reallocation of attention to external factors versus things like negative affect, which would increase attention, or selective attention, which literally means to be attentive about this somatic information selectively. So once we get signs, or once the patient detects signs of things in their body, they understand it. They try to understand it and see if it's something bad or not. And we have different sets of information which they can run through. There's different sets of information that basically makes it more or less likely that they understand signs or symptoms. And we're going to go through sets in the next slide. But we have another thing called an high internal focus. So this is different to selective attention. It is important to understand that for some reason this, even though it sounds a lot like selective attention, this is going to increase symptom perception instead of sign perception. So yeah. Okay, so sets. Symptom interpretation is influenced by different sets of stuff. So different genders would interpret symptoms in different ways. Cognitive development, so you need a framework to understand illness to interpret symptoms. Cultural models, so you need different cultures have different ways of responding to symptoms or to sets to understand symptoms. Familiarity of owners and individual differences both also influence symptom perception. All right, so one more thing. So there's a thing called the symmetry rule. So we go through this three-step process, which is sign, which is what they observe, symptom, which is what they understand, and label, which is what they think they might have because of the symptoms. But it's a two-way street, meaning label can go to symptom and sign as well. So for example, let's have a look at this. So those people without symptoms are less likely to attach a label. So even if people have hypertension, but they are asymptomatic, if they are asymptomatic and don't feel like they are sick, and they don't attach the label of being sick or having hypertension, they can end up having poor adherence. Equally, those who are told that they have a label, that they have hypertension, they report more symptoms. So people who, if they're not told they don't, if they're told nothing, but they do have hypertension, but they don't feel it, they don't feel like they do have hypertension. But if they're told they have hypertension, then they report more symptoms to explain that hypertension. So people who are told their blood pressure is high, they reported more symptoms, even if it wasn't. So label can create signs and symptoms as well. However, the dangerous part is when asymptomatic people fail to understand that absence of symptoms does not equal that it's unimportant. So yeah. All right, so this is one more model called the common sense model. And this is a framework of understanding how people cope with becoming ill. One thing is that it assumes that the individual is an active problem solver. And it looks a little bit like this. So you have symptoms on the left-hand side. So those are the messages, which are then perceived. And on the top row, we have the physiological understanding of the illness. And in the bottom row, we have emotional understanding. And both are very important when it comes to coping with an illness, since there are practical things to do and also emotional coping to do. So illness representation, understanding of the identity of your illness has 4 different aspects, as you can see. So you have the label. So it's understanding what it is, label of symptoms, understanding what it is and what it does to your body. Consequences, so the expected outcome of it. Cause, what caused it. Control is if the patient has control over the illness progression, like, is there anything that they can do? Timeline, so that's the duration of the illness and what's going to happen. After the patient understands that, then comes coping for illness control. So it's what can they do about this illness? Again, control is a big aspect of it. So can they take medication? And then once they apply their coping mechanisms, then they can appraise the outcomes of the coping mechanisms. How am I managing with this illness? Is it working? And the same is reflected on the emotional side as well. So identity or understanding of emotional reaction. How do I feel about it? Then comes, what can I do to make myself feel better? Coping. Then how am I managing with making myself feel better? And that's the common sense model. Very practical problem solving attitude. Okay, so attribution. So attribution refers to the processes of people understanding what's happening to them. So this looks like, so we say sentences to ourselves about our illness, and shifting the perspective to a different way can be beneficial. So for example, external and internal attribution. External attribution would be X happened due to something. So I became sick because my boss worked me too hard. Or internally, I got emphysema because I smoked. One detaches responsibility and one attaches a lot of responsibility. And we can have a balance of that is probably healthy, because we want to have some amount of control, since we want to be able to fix that. So some internal attribution is beneficial. There's other ones as well. So stable versus unstable. Stable is if it's persistent over time. Unstable is if the attitude is non-persistent. So that is more optimistic. So I'm unable to stop smoking now because I feel stressed at work, rather than I'll never be able to stop smoking. Global versus specific. X impacts all aspects of my life, or X impacts some aspects of my life, and I can still do some things. Controllable versus uncontrollable. I can prevent X by doing Y, or I cannot prevent X at all. Different perspectives on the same thing. So attribution errors. There are two main errors when it comes to attribution. One is fundamental attribution error, and the other one is actor-observer bias. So fundamental attribution error is when the observer, an external observer, underestimates external factors and overestimates internal factors. So they're essentially blaming the individual. So they think to themselves, the external observer thinks to themselves, he got diabetes again because he's lazy and cannot control his diet. An actor-observer bias is the opposite of that. So instead of the observer, we have the actor themselves overestimating external factors and underestimating internal factors. So that's blaming the environment essentially. So for example, I got sick because my friends didn't stay away from me. That's that. Biases. Three different biases. Self-enhancing bias is attributing success to personal factors. So that's internal understanding of success. Self-protecting is attributing failure to situational. So that's blaming the environment, sort of. And you have self-handicapping bias, which is publicly announcing that external factors will cause failure for a future event. So it's kind of like saying, lol guys, I haven't watched any lectures and I'm going to fail before you go into an exam. It's kind of like handicapping yourself so you don't feel bad if you actually do fail, I think. And they essentially protect and enhance self-evaluation. So we just talked about becoming ill, all the different stuff that comes into that. And now we're going to talk about being ill. It's going to be a bit shorter, I believe. All right, so help seeking and delaying help. So when you are ill, help seeking behavior is essentially a coping mechanism. But it's a complex decision, the decision to seek help. And it's, first of all, it's problem focused because it's a coping mechanism, problem-based coping mechanism. It's intentional because you want to, it's an intentional action. Interpersonal in nature because it involves usually asking someone for help, but you can also access help individually through self-help. And in terms of diseases, it's improved if it's visible, painful, destructive, frequent, if it's novel, if it's understood as serious, and it's past family history, so you have prior understanding of it. Also, for all this stuff, it's best if you understand it instead of remember a list of it, because when you do multiple choice questions in exams, it's less so of recalling, but rather recognizing. So if you understand how a disruptive disease will improve help-seeking behavior, that's enough. All right, so illness delay is time between illness recognition and medical seeking behavior. So that's delay in help seeking. And that can be due to a lot of different stuff. So it can be due to emotional response to symptoms, and that's avoidant if you wish to avoid those emotions. And the reasons change depending on the development stage you're at. So younger people, they literally don't have the cognitive sets. So just remember, symptoms to signs is influenced by sets, which is symptom interpretation, signs to symptoms. For young people, coping mechanism is an illusion of invulnerability, so they feel they're invincible. That's fine. Middle-aged people, so it could be a social role of not showing weakness. And older people, they could believe that help might cause a loss of independence. So yeah. All right, so when you're sick, when you're ill, there is a role that you have in society. And this role is an ideal that involves 4 different aspects. Firstly, you're excused from normal roles and responsibilities. You're excused from the responsibility for becoming sick. So it's not your fault, really. And you individually want to get better, and you cooperate with competent help to get better. This role is usually applied in different ways. For example, I think the example given was IV drug users. They're not really excused from the responsibility of becoming sick in the eyes of some people, and that can change the way they interact with society because they might not fit the sick role for some people. So this is 4-stage process: uncertainty of what's to come, disruption to activities, striving for recovery, and restoration of well-being. So that's just a way to understand impacts of illness. Quality of life. So quality of life is dependent on many different things and is different for different people at different stages of their life. So children, it's what really impacts quality of life is schooling, peer relationships that are impacted. In adulthood, it's more dependent on roles and responsibilities. And in old age, your priorities can shift. So valuing independence, quality of life, socializing, medication, attitudes, meaning in life, all of them impact quality of life and the way it interacts with your illness. Aspects of the illness as well. Disease. So it's not necessarily that the most severe illness has the worst quality of life, but it is strongly associated for some symptoms, such as Parkinson's. Treatment. So not just the illness, but the treatment can be a huge burden, especially for things like cancer. Emotional state. That makes sense. Coping mechanisms used as well, and social support. All right, so we're going to talk about social support, which is the final point for a bit. A lot of people care for others as a full-time or part-time carers. And there are a lot of there are a lot of benefits and downsides of being a carer. But before we get to that, the impact of illness, there are three different, you can think of it as another three-stage process for how your interpersonal relationships alter and shift due to you being sick. So firstly, there's resistance, that's denial and grief. There's restructuring, so restructuring routines and roles in life, and consolidation, which is the restructured roles consolidating and formalized and being formalized. But that is super relevant when suddenly someone becomes a carer for someone, their new role in life. There are many benefits for those being cared for. So those with an active carer in their treatment have increased treatment adherence, better adjustment and coping, better biological functioning, reduced mortality. So it's all really good outcomes. There's some benefits for carers as well, so that they have general sense of fulfillment, personal growth, pride, increased closeness, and all can act as buffers to the negative aspects of caring. And usually the burden on carers, when it becomes negative, is when there's an imbalance between the demands of caring and available resources. So kind of like the transactional model again, but yeah. But helpful caring is pretty nuanced. You don't want to be over caring, you don't want to reduce their independence, and you don't want to reinforce the sick role they have. It's more a practical assistance, expressions of love, concern, and inconsistency of care. But yeah, that's the end of that.
Just share my screen. So we're going to talk about refugees and asylum seekers and the health issues they might face or the health determinants. Firstly, we have some statistics or facts about refugees around the world. So there were 13 million more displaced people in 2018 than 2017, which is a very, very huge number. And most of these 13 million people, or more than 2/3 of these displaced people, were from 5 countries that are facing civil wars or political issues. These countries are Syria, Afghanistan, Myanmar, South Sudan, and Somalia. And over half the world's refugees are children. So we might face a very serious health issues. And that's why it is important to know the health determinants or the health issues that refugees are facing currently. So we have firstly some terminology and some definitions about some words that we might face. Firstly, refugee. So refugee is a person who's outside their own country and unable to, willing to return to their country due to political or any other issues that regarding their race, religion, membership of particular social group, or political opinion. Because if they return to their country, they might be persecuted. And we have also asylum seeker. Asylum seeker is someone who's seeking international protection, but their refugee status has not yet been confirmed. So he is not, or asylum seeker is not yet to be a refugee. We have internally displaced people who are still in their country and cannot fit under the definition of an asylum seeker. So they are unable to gain refugee status. We have climate refugee who are not protected under the United Nations Refugee Convention and cannot receive protections. Finally, migrant who's choose to leave their country, not necessarily because of fear or they were forced to leave, but for other reasons like looking for a better job or better lifestyle. We have pre and post arrival factors that might affect the health of these refugees or asylum seekers. Some of pre-arrival factors, including standard of health system in country of origin, especially countries that there were civil wars in them, so health system might not be able to perform that good. Experiences of the individual, they might have some physiological or psychological issues regarding their health. They might have trauma and then poor access to healthcare before entering to Australia. And some of the post-arrival factors, difficulty accessing healthcare in Australia, problems with health screening, forced detention. We'll talk about that just in a second. Institutional prejudice and cultural insensitivity, some cultural issues that might they face in the country they migrate to. Some language barriers, access to financial resources, final knowledge and ability to negotiate the health system. So Australia's current policies regarding refugees or asylum seekers, Australia is accepting 18,750 refugees every year. And this might be divided to offshore and onshore processing. So the main difference between offshore and onshore is that in the offshore, the refugees, before they come to Australia, they already have a valid visa and they are officially classified as refugees by the United Nations High Commissioner of Refugees. However, on onshore processing, people are not yet classified as refugees, though, so they claim their refugee status or apply for asylum, apply as to be considered as asylum seekers after on their arrival to Australia. So offshore, people arriving by a plane with a valid visa as we said before, they're classified as refugees by the United Nations High Commission of Refugees. And the Australian government provides support to these people, including access to school, free accommodation, and free flight to come to Australia. For the onshore, the Australian government offers protection to these people. However, they will never be allowed to live in classified as unauthorized refugees or arrival, or illegal arrival and authorized arrival. So people who arrive to Australia by boat can be considered unauthorized, where they carry no visa, they are not eligible to live in Australia forever, and they will be sent to offshore detention in Nauru for indefinite mandatory detention. And this is like the onshore policies are controversial because of this indefinite mandatory detention, where Australia sent these refugees to another countries to stay in there for detention. And then the authorized arrival, where people arrive by plane, and they already have tourist or student visa, but not a visa as a refugee. So they apply for a bridging visa after their arrival to Australia. Now we'll talk about how, as a doctor, to start with the patient who's a refugee or asylum seeker according to the Australian Society of Infectious Diseases. So there are three main things you need to do: ask, screen, and kindness. You may use the word ask as acronym for this. So A for ask, S for screening, and K for kindness. Firstly, when asking these patients, you need to ask for the country of origin, their ethnicity. You need also to ask about their arrival details. When did they arrive, their visa type, and how much they spent in detention. Then you need to also ask about the language they speak or prefer. You need to ask also about their occupation and access to education, their current stresses, because usually like these refugees have many problems. Either they can be physiological or psychological, like housing problems, education, financial, or working. You need also to ask about their interpreter. Do they need an interpreter if they are not able to speak English language, their preferred language, and also their gender preferences, because some refugees, for example, due to probably religious reasons or any other reasons, they, like females, prefer to be treated by female doctors. Then you need to ask also for priorities. So we need to balance their health needs with their personal needs and their personal situation. And finally, assess, listen to their values, their wishes, and their needs. Next, we have screen, where so screen should be both for physical and psychological issues. Before screening, we need to ensure that informed consent is obtained, and then we perform screening tests, including immunization status. Screening or screen tests can be divided into three categories. First one, where all asylum seekers or all refugees should be screened for these diseases, including hepatitis B, HIV, strongyloides, varicella, dental hearing, and visual testing, and other tests. Then risk-based screening. So these screening for people who are at risk of having these diseases, for example, rubella for women of childbearing age, vitamin B12 for babies who are less than 6 months, or people who had food insecurity problems, or vegans, and people from certain countries like the Horn of Africa. The last category is country-based screening. So people from specific countries must have this screening because, for example, this disease is common in these countries. So we have malaria, schistosoma, and hepatitis C. Lastly, we have kindness. So this is more how to communicate with the patient, or with the refugee or asylum seeker, and how's the relationship between you two should be. So doctors should coordinate and integrate, integrate care. They should offer, like if longer appointments, these refugees or asylum seekers need to be reminded like one day before the appointment that you have an appointment tomorrow, because probably lack of the understanding of health system, for example, in Australia. Doctors need to consider the social issues. Obviously, as they are refugees or asylum seekers, they have lots of social issues they carry since they came from their origin country, financial issues, housing issues, and other issues. And then sensitivity, you need to be sensitive and watch the words you are saying, because because of the burden they carry. And finally, health service info, because they might not be familiar with the Australian health system. They need to be educated about the health system in Australia, how does it work, and how they can negotiate the health system itself. And that's it for today's presentation about refugees and asylum seekers. Thank you so much.
That's very, wow, my voice is gone. Thanks very much, Marwan. And I'll be bringing up the very last one of today. I'm going to be talking just a little bit about basically exam revision and some advice from the PSPlatypus team about how to go about that, which will hopefully serve you in good stead. So let me bring that up for you. Okie dokie, I'm going to assume everyone can see that. So, so you guys have exams coming up in about a month or so. And you might be wondering, how do I revise? What's going on? This is so different from school. You guys all did well in BCE. You all have a pretty good handle on how to revise in general. But that doesn't mean that there aren't still certain things that are unique to MED, which are still just general good advice that you should aim to follow when you're revising for your Sem 1 exams. All right, so the biggest thing I can tell you is start to revise early. So this is sort of a dual thing. So first of all, make sure that you limit, or ideally don't fall behind at all, because if it gets harder and harder to catch up over time, if you let yourself get really behind in lectures, workshops, all of that stuff, it becomes a bigger and bigger task to actually catch up and then go beyond that to revising. So you want to be able to start early. You want to be comfortable and be able to identify really quickly the areas where you're struggling at. And the only way to do that is to be able to start early. So limit how much you fall behind, and be aware that like by now or even earlier than now is around the time that you want to be starting thinking about, okay, well, exams are coming up, what do I need to do? And then you also need to make sure that when you do practice, it sort of work smart, not hard. Although you will have to work hard as well. So, I mean, work smart and hard. But the basic idea is that some things are more effective than others. So practice exams are probably the most effective tool. That's the general consensus of our team. Basically, the idea is that we want to make it as similar to the real thing as possible. Because that's going to give you the most accurate test of your abilities, and therefore the best picture of what do I need to work on. And do make sure that when you're revising, you're focusing on the areas that you're least familiar with. So focus on your worst stuff, not your best stuff, because your best stuff will feel the best of practice. It will feel like you're getting somewhere, but you'll also not really improve much if you're already really good at a topic. Whereas if you are bad at a topic, then you'll be able to get a lot of improvement by working on it. And it will be hard and it will be annoying, but it'll be a lot more effective for you in the long term than just working on the stuff that you're already pretty familiar with and happy with. And yeah, so just in general, focus on active recall methods. So like, don't rewrite notes for your revision, that sort of thing. It doesn't really give you much in the end. It's sort of just a short-term thing which doesn't end up testing whether that stuff has actually been committed to memory, and whether you're able to recall it on command, which are the things that are actually important in the exam. So we want to generally make sure that whatever things we're using, whatever methods we're using, are as similar to the real thing as possible. Because again, that will give you the best picture of how you would actually perform in an exam situation, and that's what's important. This, I don't know if you guys have MONSKIs, like the clinical skills history taking stuff, but so that one, again, the best possible test isn't to just read over your notes, it's to find someone, go and bug your parents or your siblings, and ask them a bunch of questions, because that's going to be the closest to the actual assessment. And yeah, and so we also want to make sure when we're doing stuff like that, that we are understanding questions beyond just, I got this right or I got this wrong, because you can learn a lot more than just that from a question. And obviously we want to get the most out of the practice that we do. So you want to know why they're asking the question. So why this format? Why this information? What are they trying to get at? Because that sort of stuff doesn't change too much between exams. They'll still have the same motivations in testing between, last year's exam 3 years ago and this year's exam. And this one is specific to multiple choice, but it's a really good option. So when we have, say, 4 answers or something, obviously one of them's right. It's one thing to say, okay, well, I got the right answer, I got the wrong answer. But really, you can think of it almost as 4 true or false questions. So you need to understand, if you want to get the most out of it, not only why the ones that's right, or the multiple that are right in some cases of poor exams, not only the ones that are right, understand why they're correct, but also understand why the others are wrong. Because understanding why the others are wrong, beyond just, well, it doesn't sound right, is usually a really good gauge of whether you understand the topic. And remember, these can change really easily. So for all you know, the question on this year's exam might be one of the options that was wrong on a previous exam. They might be testing something slightly different. And so that's a really effective way of practicing for multiple choice stuff. All right, and then also your faculty, I believe, will have sent you exam blueprints. So if they give you sort of a list of topics which are going to be in the exam, which is sort of just a summary of what you've done so far. And also they'll give you a sort of a pie chart, a breakdown of how many marks are given for each thing. I think for you guys there'll be like heavy anat, biochem, and maybe some physio focus. That would be my estimation. And so yeah, they're a good idea on where do I actually need to put my energy? Where do I need to put my effort in, and how much time should I be spending on each of these? So do make sure you're not spending a huge amount of time on something that's unimportant, and that you don't neglect the stuff that is a big topic. That said, if anything, they're a good indication of why you shouldn't just neglect like HKS and HEP, because they are like quite relevant in the end. They make up a pretty decent portion of your grade, not a huge portion, but a pretty decent one. And if you're not revising those, then you're leaving those marks on the table. So I guess the little modulating thing for that is that they can be tested a little weirdly, a little differently, especially to other topics. So like HKS is usually assessed using short answers, which is a little bit different, but still obviously focus on the practice exams. And HEP is usually, they assess it usually based on like a bunch of little certain questions that they almost reuse between years. So like they'll ask about the Mediterranean diet or the risk reduction for such and such. So it's a lot more idiosyncratic. So like that, for those, past exams are super important. And don't expect to know like every statistic. You'll net like, there are 50 slides or something in every lecture, and half of them have like 3 statistics on them. You're not going to know all of those, but do pay attention to the ones that keep popping up in exams. Come to PSPlatypus, of course, that's 100% exam success. And of course, don't stress. So like year 1 and year 2, they don't contribute to your Z-score, which is the thing that is used in internship applications way forward in the future. And you all have an incredibly good chance of passing. We I don't know of anyone who dropped out of med last year. And of the people that I know who did remedial exams, so that's when you land within the range where it's not a fail, but they get you to do another exam. That's a very small portion of the cohort, because again, you guys are pretty good to get into med in the first place. All right, and the last thing, so this is when you're looking for practice exams and other materials. So everyone's talking about practice exams, but where do you actually find them? Faculty should have sent you some emails about this, but basically there's a platform called Equella where they release a certain number of them. It's not a huge amount, but they're official ones, and they're relatively recent usually. So definitely have a look at those. They're quite valuable as a revision aid. And your academic reps might also be able to scrape some together. And those should be on like that Notion page that's set up for you. ePharmacology is a really good website for pharmacology. So I believe the core drug list is on there. And then also you'll have a lot of information about certain drugs, which is quite useful because that's going to be a big bulk of your pharmacology stuff. I think you're basically picking up on it now. You won't have a huge amount of drugs for SEM 1. SEM 2 is when it becomes super important. All our recordings and all our slides and our quizzes are all available. I should put a link to our drive on that slide actually. But yeah, they're all available. You can look at them at your leisure, reread them, watch them at 3 times speed, whatever you want. MUMIS will also come out with a bunch of revision lectures. I think they've already done some, and there'll be more at the end of term, that sort of period. And they'll go up in the YouTube. They're less detailed than our ones because they compress stuff even more to fit into a smaller time period. But they're quite a good overview. So like if you want a more, a quicker look at a topic, which still hits on most of the major like high yield stuff, then they're a good place to start. And yeah, and you've also got more stuff in that Notion Hub, again, maintained by your ACREPs. Remember, thank you, ACREPs. They do a lot of work to help you obviously get prepared, and do pay attention to everything they come out with, because obviously there's a lot of good stuff which gets buried sometimes. Quick plug for study designs. If you want the Word document, ask me. Yeah, that pretty much finishes us up. I think that covers everything. So if you have any questions, feel free to check them in chat. Otherwise, have a good day, and we'll see you next week.
Thanks for coming. See ya.
Thank you, guys.